Hello, everybody, and thank you so much for joining us today. So, those of you joining for the first time, my name's Tommy Bayer, founder of the Aphantasia Network. That was one of the first 21 cases of aphantasia identified in the landmark paper coining the term back in 2015. At the time, aphantasia was just an obscure term in an academic journal. But now, thanks to a large part in your community support and the surge of new research interest, aphantasia has grown from a grassroots movement into a whole new field of study. Today, October 10th, is World Mental Health Day, an international day for global mental health education, awareness, and advocacy against the social stigma. I'll start by saying that although aphantasia itself doesn't meet the threshold to be classified as a disability, we do know that for about 30% of folks who learn they don't visualize, well, they do experience a type of psychological stressor from the discovery. That data comes from Merlin Monzel at the University of Bonn, for those who are interested. But in addition to the discovery of your own aphantasia, I think it's fair to say that there's a common belief that's emerged in the community that aphantasics don't experience PTSD or some of the other related challenges. And I think this is a perfect opportunity to tackle those types of claims. So, with that in mind, I'm excited to be discussing aphantasia and its impact on mental health care with two researchers behind the largest study to date exploring the topic. So, I'd like to introduce Dr. Reshanne. Dr. Bridget, thank you so much for joining me today.
Thanks for having us.
So, for everyone watching at home, I'll be handing over the stage to Reshanne and Bridget, who will each do about a 10-minute presentation introducing themselves and discussing their research. Once they're done, I'll join again for a discussion and to answer any questions that you leave for us in the live chat. So, if everyone's good with that, Reshanne, I think we'll pass it over to you. Get started.
All right. Thank you very much. I apologize in advance if there's any crackling or if I cut out at any point. I'm also in Florida right now. I see somebody who's in Orlando. And the hurricane has been passing over, so the Wi-Fi is not amazing, but let's see if we can get through this. I just want to introduce why we decided to investigate this topic to begin with.
Okay, a quick note for our viewers. You'll notice a change in both video and audio quality when Dr. Reshanne presents her segment. Due to connectivity issues during her original recording, she kindly re-recorded her entire portion with new slides to ensure you can fully appreciate her research findings. The content remains the same, but both the visual presentation and audio have been replaced for better clarity. Now, back to the presentation.
So my background is in visual perception and individual differences in visual perception and mental imagery. And in about 2019, that's when I learned about aphantasia as a topic that you can investigate scientifically. However, over the course of the last few years of research, and as I'm sure many of you already know, a lot of aphantasia research has shown that there are not many objective differences in visual perceptual performance, or even classical psychological tasks that are thought to require mental imagery, like different types of visual memory and mental rotation tasks. The biggest differences we've found are in subjective experiences. So I've been really interested in the past couple of years looking deeper into the subjective experience of aphantasia and how this affects people's lives on a personal level. The research we're going to be talking about today is on how aphantasia might affect people's mental health experiences. As we know from previous research, aphantasics are very unlikely to experience sensory symptoms like flashbacks and PTSD. And we wanted to understand more about these symptoms and how they impact mental health care experiences, such as evaluation and diagnosis. We also wanted to know what kind of therapies aphantasics have tried, what works and what doesn't. What we did was Bridget and I paired up with the Aphantasia Network, and we conducted a large-scale study that started with a questionnaire advertised via an article that we wrote for the network called Revisualizing the Role of Aphantasia in Mental Health Care. We asked a lot of questions about to what extent aphantasia impacts experiences with seeking mental health care and symptoms of different mental health conditions. And we gave this questionnaire to thousands of people, and maybe even some of you filled out this questionnaire through the Aphantasia Network. And we asked people about their mental imagery abilities. We also had quite a few people with hyperphantasia who filled out our questionnaire. That's extremely vivid and hyperrealistic imagery. We got responses from people across the mental imagery spectrum. We asked about mental health evaluation and diagnosis experiences, and if they've ever had intrusive sensory and emotional experiences like flashbacks. And then we asked about the types of treatment that they sought, and also treatment success, and what mental health conditions they sought mental health care for. Overall, when we pre-processed the data and looked through all the questionnaire responses, we got 2,405 aphantasics who responded, and 410 people with typical imagery to hyperphantasia, who we called our imager group for this study. And I'm just going to provide some bullet points on some of the findings that we got in the questionnaire. First, in terms of demographics, we considered aphantasics to be those who scored less than a 3 out of 10 on a visual imagery vividness scale called the PSIQ. And then those who were part of the imagery group were those who had scores greater than 3 out of 10 on that scale. What you can see here in the figure is that each dot is an individual participant. The imagery group is shown in this peach color, and the aphantasics are shown in blue. You can see there's a wide diversity of visual imagery vividness scores of our participants, with most people clustering around the extremes, which is what we wanted to represent in this study. And we got a lot of responses across the world, most of them from the USA, Canada, UK, and Australia. But you can also see there were quite a few responses from other parts of the world, such as South America, African countries, Russia, India. And then we also asked people where they sought mental health care, and that was also mainly in Western countries. So just something to keep in mind as you listen to the presentation, we did try to diversify our demographics as much as possible, but this is mainly representative of the Western world. We also had a high proportion of female respondents. About 78% of our respondents identified as female. About 95% of our respondents had advanced or native English skills, and they came from middle-class socioeconomic status. There was quite a bit of diversity in these demographic distributions, but there were actually no significant differences in these distributions between aphantasics and imagers, which is very good. So the groups were quite well matched. However, the aphantasia group was slightly older, not so much significantly older, but you can see from the graph here, where it says age in years, the aphantasics are shown in blue, and the imagers are shown in this peach color again, that there's a wider age range represented among the aphantasics, whereas the imagers tended to cluster more towards the younger side. And then we also had the highest level of education at the bottom here, broken down from primary or elementary school all the way to doctoral and professional degrees. And what you can see is that there is also a very similar distribution of educational attainment among aphantasics and imagers. So let's move on to some of the main results of the survey. So we asked participants to report from a list which mental health condition or conditions that they experienced, and participants could also write in their own responses if their condition wasn't on the list. First of all, I didn't include neurodiversity conditions here, since these are not considered mental health conditions, though the most common write-in conditions were autism and ADHD. And in case anyone is interested to know, there was also no difference in the prevalence of autism in our groups, which maybe settles the old misconception that autism is more prevalent in aphantasia. But importantly for our study, there was also no group difference in the prevalence of most mental health conditions, including depression and anxiety disorders, which are often thought to be exacerbated by mental imagery. And very interestingly, although you can see a small numerical increase in PTSD among imagers compared to aphantasics in our samples, this difference was not significant. About 20% of our aphantasic sample had sought mental health support for PTSD, compared to 25% of imagers. There were two conditions that showed a significant difference in prevalence between aphantasics and imagers, and those were bipolar disorder and obsessive compulsive disorder, both of which were more prevalent among the imagers. It's been suggested that people with aphantasia may not experience intrusive imagery to the same extent as imagers, such as flashbacks and PTSD. And when we talk about intrusive imagery, it's usually in the context of PTSD flashbacks, but other disorders can have intrusions as a symptom as well. such as negative body image in eating disorders or worst case scenario intrusions in anxiety disorders. And generally, we found a higher prevalence of intrusions among imagers in our sample when we asked participants to report if they'd ever had an intrusive experience as part of their mental health condition. About 70% of aphantasics said no, whereas about 75% of imagers said yes. However, if we break down reports of intrusive experiences into different sensory modalities and also include reports of emotional intrusive experiences, we find that the biggest differences between aphantasics and imagers was in the visual domain, whereas there was no difference in the prevalence of emotional intrusions. Emotional intrusions were actually the most pervasive form of intrusions for both groups, and this includes invasive emotional experiences like waves of panic or sudden sadness related to thoughts and memories. So we thought that was a very interesting finding that people with aphantasia are not protected against emotional intrusions, which are the most common type of intrusions for both aphantasics and imagers. Then we broke down the prevalence of intrusions reported across different mental health conditions, and we found differences across the board between imagers and aphantasics. And this was particularly striking in PTSD, where over 90% of imagers experienced intrusions as part of their PTSD, whereas only 43% of aphantasics with PTSD ever experienced intrusions. So we expected this could be a major barrier in seeking mental health support and diagnosis, especially since flashbacks are considered a core symptom of PTSD. Next, we asked people about their experiences seeking a diagnosis for their mental health condition. Most aphantasics who had received a diagnosis believed they had been properly diagnosed, which was a pleasantly surprising finding considering the differences in mental health symptoms for aphantasics. Most of those who believed they had been properly diagnosed suspected they were diagnosed based on symptoms that were unaffected by aphantasia or unrelated to aphantasia. Over half of aphantasics who did not feel they were properly diagnosed suspected that aphantasia may have delayed or prevented a diagnosis in some way. This was particularly true for aphantasics with PTSD, for which intrusive images are a core diagnostic symptom. So almost 75% of aphantasics with PTSD felt their proper diagnosis of PTSD was delayed or prevented because they did not have visual flashbacks. In terms of mental health evaluation experiences, 75% of aphantasics believed they had been properly evaluated for their mental health condition. But among those who felt they were misevaluated, more than half of those believed aphantasia may have factored into the misevaluation in some way, particularly due to a lack of understanding of aphantasia by mental health practitioners. Something else that it's important to be aware of is that many people only find out they have aphantasia long after they seek mental health care. So at the time of seeking an evaluation, it's not just the practitioner, but also the individual seeking treatment that might not be aware of their aphantasia. And this can be a potential barrier to effective evaluation and diagnosis. Finally, we wanted to know how many of our participants had tried cognitive behavioral therapy, also called CBT, which is currently the most common form of mental health treatment out there for a variety of disorders. CBT often relies very heavily on mental imagery techniques, so we targeted this therapy specifically to gauge its perceived effectiveness among aphantasics and imagers. So first off, we found that about 70% of both imagers and aphantasics had tried CBT as part of their mental health treatment. However, among those who had tried CBT, there was a difference between aphantasics and imagers in the perceived effectiveness, with about 80% of imagers finding it at least somewhat effective, compared to about 60% of aphantasics. The type of CBT they tried included a visual imagery component. The perceived effectiveness of the treatment went down to 50% for aphantasics. However, if CBT included non-visual imagery techniques, its effectiveness went up to 72% for aphantasics, which was not significantly different from the perceived effectiveness of CBT for imagers. So if the practitioner did not rely on visual imagery in their CBT toolkit, it could be equally as effective for aphantasics and imagers. To conclude, from the quantitative analysis of this survey, We found there was a similar prevalence of most mental health conditions for aphantasics and imagers. However, sensory intrusions like flashbacks are much more prevalent among imagers compared to aphantasics, which could contribute to delayed or prevented diagnosis in aphantasics, especially for those with PTSD, for which intrusive images are a core diagnostic symptom. And despite a similar proportion of aphantasics and imagers who've been referred for CBT, significantly fewer aphantasics found it effective as part of their mental health treatment. But a silver lining is that if practitioners focus on non-visual imagery techniques in their CBT protocol, it can be just as effective for aphantasics as imagers.
So that was very interesting for us. But we have the research project where we delved deeper into people's personalized experiences. And that's what Bridget is going to talk to you now about.
Thanks, Reshanne. As Reshanne was explaining, she's been working and looking at the kind of cognitive and the differences between aphants and images through her research. For me, I was initially trained as a psychotherapist, and I then worked in schools for a very long time, coming a little bit later on to my research journey. And I work in the Faculty of Health, looking particularly at mental health and the way that mental health services interact with our populations. So Reshanne and I were able to work very well together to construct this piece of research, looking at not only is there a difference in terms of whether or not there's a problem between the way that people who are images can access mental health services compared with aphants, or is this something we even need to ask questions about? Because the research was suggesting that there was a difference in the way that this was experienced. And for me, it was more important, or as important, to then delve a little bit deeper and ask people's questions, ask people about their experiences. And so we conducted some interviews. So we selected people who had completed our presentation, trying to get as broad a spectrum as we could so that we could get a representation of the experiences from as wide a range of people as possible who have had the experience of aphantasia and who had been seeking mental health support. We asked 13 males, 8 females, and 1 person who was non-binary. Everybody had the opportunity to describe themselves and their gender in the way that they chose to. And we asked people questions and interviewed people from between the ages of 18 and 67. So it was quite a broad spectrum in terms of age. And we tried to spread out economically who we were asking questions or who we were inviting questions from. And we also tried to gather opinions and experiences, not just of a single mental health system or healthcare system. We were trying to gather as information from as broad a population as we could to see if there were any kind of similarities or differences in the way that mental health services could support people with aphantasia across the globe. We had some key things that we asked people about during these interviews. We asked them about their experiences of being themselves and trying to understand themselves as an aphant. We asked them about their experiences of diagnosis and their understandings of themselves by professionals or the services that they interacted with. We asked them about their experiences of interventions that they had been offered when seeking support for mental health problems. And then we asked them if there were any experiences that they had of techniques that helped them or techniques that meant that they couldn't engage with mental health services. Then we pulled all of the information together because we wanted to hear what the voices were saying. And while individual people's voices are really important and they help us to paint part of that picture, we try and draw together themes and to look at kind of similarities across there. And what we came up with, what we identified across the way, is that there was a push and pull going on. So we had people who were seeking mental health conditions and were on a quest to understand themselves a little bit more. And part of that meant that they needed to understand themselves as an aphant, about whether or not they were different and comparing themselves with other people. We found centrally this theme of memory and the way that people remember things, and then the sort of help-seeking behaviour and why they were seeking help for support. Because in general, people seek mental health support because they're struggling to interact with the world around them. They're struggling to find their place and their way within the world. And it meant that people were in trying to understand themselves went on a personal mental health journey. There are as many mental health conditions, challenges, experiences as there are people on the planet. So this is trying to understand the themes that kind of go along with that and things that can make things easier or not. And we actually found, very similar to the data that Reshanne was explaining earlier, quite a big difference in terms of the experiences of people who were seeking mental health care support depending on the type of mental health condition that they were struggling with. So we found that aphantasia impacted people who were then came to the conclusion that what they had was in the space of like anxiety or depression, which is the most prevalent mental health condition that we know about and that we have information on. They were less impacted by their aphant in terms of their experiences of seeking mental health care. Then we had people who were neurodiverse for whatever reason. You're thinking here around autistic spectrum, we're talking about ADHD and all the neurodiverse categories. They had a different mental health care experience, but they also didn't find that their aphantasia impacted too much with their ability to get a diagnosis or to seek support for their mental well-being. The biggest difference in terms of what we were looking at was around trauma and complexity. And that kind of bears out a little bit what Reshanne had been saying. So people talked about their differences and comparing themselves with other people by kind of the way that you find out that you're different or that people think differently to you. The same way that people recognize that they're colorblind, they compare what they can see, what their experience is, by asking their friends and family, by talking to the people around them. And there were lots and lots of different experiences of aphantasia. Firstly, this realization that they don't experience things in quite the same way. Then thinking about how they interact with the world around them. And there was, in the end, a kind of reconciliation or positivity around being an aphant. It wasn't something, it was something that they adopted as part of their identity, which I think is really important. There was lots of conversations around memory, which has an interesting kind of connection when we start talking about some of the mental health care that we can access, because some of it is involved, or some of the theories or the practitioners are involved around going back and accessing memories of things that were difficult for you and being able to process that. And if we're struggling with memory, it can make accessing those spaces a little bit more challenging. So we found that it was very important, or very what people were speaking about was about what it felt like now being in the room, being in the space that they were occupying. And then we think a little bit about why people seek help, and the experience of help seeking from quite a lot of the people that we spoke to was that they weren't quite sure that the professionals who were working with them really understood them because of a maybe lack of understanding of aphantasia and what it is. Those people who were experiencing anxiety and depression and didn't find that much difficulty in getting those diagnoses, when you've got enough answers about who you are and your self-identity, you stop looking a little bit. So those people who felt that the diagnosis of anxiety or depression, or kind of in that space, answered the questions about why they were struggling to interact with the world around them, then found that they were able to build tools that were potentially personal to them, that they could adapt and to live their life and to get on with it. And then they didn't need to continue their mental health journey or the quest for understanding themselves in relation to the world. For those people who were looking in that neurodiverse space, there was a level of, actually, this now answers my question about who I am. And it didn't necessarily matter so much about the aphantasia, because the diagnostic criteria, the way that we understand autism, for example, ADHD, doesn't really cross over with any of the symptoms that you might experience, or the experiences that you might have as an aphant that would be different from a typical imager. The big difference came with this kind of trauma and complexity space, which encompasses PTSD, DID, which is dissociative identity disorder, bipolar disorder, the things that are a little bit more complex. And the biggest issue here has to do a little bit with how we interact with our services and the kind of diagnosis, the things that our practitioners are looking for when they come to make these sorts of diagnoses. And it bears out again what Reshanne was saying with the numbers that we come to from the questionnaire, in that sometimes in some of our diagnostic and our way of understanding the differences between some of these conditions, things like emotional dissociation, for example, is as in, I'm experiencing an emotion right now that doesn't bear any resemblance or isn't connected with the experience of the world around me. What I'm feeling doesn't match what I'm experiencing. And this kind of emotional disconnectedness is more associated with something like dissociative identity disorder, or DID, than it is with PTSD. But if people with aphantasia are tending to experience their, for want of a better word, flashbacks, those emotional putting yourself back in that space, there is a potential for confusion in terms of diagnosis, with a professional not understanding that it's an emotional flashback as opposed to an emotional dissociation from what's going on beside us or around us. And really, it's about trying to understand ourselves in relation to the world around us and understand the experiences of aphantasia and how to adapt to aphantasia to make their lives work for them. And those people along that mental health journey were continuing to ask questions until they got an answer that they felt authentically matched their experiences in the way that they interact with the world around them. And how many times they needed to continue to go looking for answers depended on the type of mental health conditions that they ended up recognizing in themselves, with those most impacted being those with the most complex mental health spaces. In terms of the key barriers of being able to access those mental health services and those supports, you're thinking about rigidity. So for those professionals for whom the technique or the method of their therapeutic intervention was more important to them than actually building the therapeutic relationship, for those people who had professionals who were more hooked on what I'm supposed to be doing, they found it much harder to access appropriate support. There's a lot of space in terms of our system, partly with the diagnostic criteria that we have and the way that we think about engaging with it, makes it possible for aphants potentially to fall through the gaps and the cracks in the system. And also a lot of our CBT techniques rely on guided imagery or imagining, and the language that we tend to use around that does tend to be more visual. In terms of supporting them, a therapeutic relationship that comes from a space of understanding and personalization, a way of adapting to being in the now and being present, seemed to make things more effective, and supported in the experiences that they were currently having. Yeah, that's what we discovered. And we were trying to do this piece of research to identify whether or not we needed to have a different way to support people who didn't visualize in quite the same way or didn't imagine in the same way. And that to us was really important. And the next steps on from this is to work out how best to go about building that kind of support.
Thank you to the both of you for those very interesting and important presentations. Lots of great comments. And for anyone else who has specific questions that they'd like to ask, you can feel free to put those in the chat. We'll try to get to them. We do have some from the Aphantasia Network member community that we'll get to first. But I want to start with a question of my own. If I had to maybe try and summarize, and you can correct me anywhere where maybe I missed some of the nuance, but it did seem like, in general, those who can't visualize seem to be able to experience most of the mental health conditions as visualizers. Some of the techniques, specifically when they used visualization or language around visualization and imagination, maybe either didn't resonate or didn't connect with the individual as much. Things like the CBT actually still worked as long as visualization wasn't really the focus of the exercise. Was that kind of like a 30,000-foot view?
Yeah, when you say that they still experience the mental health challenges, yes, they do. And in all the conditions, yes, they do. Because of this visual flashback thing, sometimes they're not recognized necessarily for what they are, particularly in that sort of complexity space.
So this kind of flashback mechanism is one of the diagnostic criteria. And because aphants aren't experiencing those flashbacks, maybe they're falling through the cracks in that piece of the workflow.
Yeah. And the challenge with CBT, so CBT is, there's a lot of evidence. And because of the way our healthcare systems work, we tend to employ evidence-based practice. So if you're going to be spending a whole load of money on this, whether it's through services like the UK's NHS or whether it's through your insurance policies or however it works, they want to be sure that they're getting value for money. So they follow the evidence. And there's a lot of research published that CBT is good for a whole range of conditions. But CBT can also be quite prescriptive in the way that it works. So you learn a particular technique and you do this, and then you do this, and then you do this. And so sometimes our practitioners that we train might find it a little bit harder to adapt those techniques to remove that imagery, especially if they don't understand what the problem is.
Yeah, and just anecdotally from our side, we often hear from folks who've tried to build that relationship with their therapist, and sometimes they're almost in disbelief, I could say, because aphantasia is still not widely known, not widely taught. And if there's disbelief, even that you don't visualize, if they don't even accept that premise, then of course the adaptations and things follow from there.
No, absolutely. And actually, it's about, we expect aphants to constantly understand that they're different from the world around them. But sometimes it's really difficult for individuals, whether they're therapists or not, to accept that other people's experiences of the world are different from their own in terms of sensory input. So that is a very difficult thing that individuals need to do, whether or not they're working in a helping profession.
Yeah, and one thing that I see actually in science and also from the interviews that we did, a lot of scientists don't believe aphantasia exists, no matter what evidence they're given. And some of the people we interviewed were saying, my therapist just didn't believe me. There was nothing I could say that could make them believe me. And that is a real barrier to accessing mental health support.
I will
Yeah.
say that it's really important, and that when we do train therapists, one of the key things is about the therapeutic alliance and building a good relationship with the client. And that's why when I was talking about the findings that we had, it's only when the technique is prioritized over that therapeutic alliance and that personalization that we have this absolute barrier. And that kind of, you go, sometimes you just don't click with a therapist, or you just don't click with a person. There has to be that therapeutic relationship and that element of trust. And it may be that that's just not the right therapist for you.
Yeah,
Yeah,
and I
really.
can see that in the comments. There's someone, Deanne, saying the relationship is critical, key. And yeah, that's exactly what we found in our research working on this project, that the therapeutic relationship is so important.
And it's because in this type of relationship where you're supposed to be vulnerable and open, to have maybe this strict adherence to process or technique over actually trying to hear and understand the unique experience of the aphant in this situation. Not being heard, it could actually, be even more frustrating, especially if they are aware of their aphantasia, and this is one of the things on their mind. Not being validated in that experience could even make it more challenging in some circumstances.
Absolutely. One of the attractions to our services that CBT has is that it's time bound. So you do a 12-week session of CBT where you follow different handbooks and different kind of processes work in slightly different ways. But there's a step by step, there's a process through which you train. And that time bound space can make it, again, also difficult to build those relationships. But it's partly what our systems will pay for that makes it really difficult to support those more authentic personalization spaces. And it can be that when you come up again and again with therapists and with practitioners who are not able to recognize that difference, that aphant difference, that you go, then therapy can't work for me. This can't work. I can't be supported or helped in this way. And there is a danger there that we can end up feeling a lot worse about ourselves than necessary when the adaptation is possible.
Yeah. How much of the techniques and literature relies on visualization? Like, how common of a technique, say, in mental health care and these type of related fields rely on visualization?
It's actually quite common. And in particular, when you look at the way that we train therapists around, for example, something called EMDR, which is eye movement desensitization. I can't remember what the
Reprocessing?
I think so. I'm really bad with acronyms. Which is a particular technique that works very well for trauma. One of the ways that we try and make it asks you to go back and to remember something that happens. And we've already talked about how difficult it can be to access those memories for some people with aphantasia as one of their experiences. But the kind of things that we do to try and elicit these memories, and the way that we would want to work, for example, with children, is to try and make it more detailed to bring back the recollection. And the language that we tend to use around that is around what can you see when you are in that space. And it's not something that is being done deliberately to make it harder for people who can't visualize, but that's the language that is part of the initial training space. And it's up to the individual practitioner then to adapt and to think about different ways. What can you smell? What can you taste? Those sorts of things that are trying to make those memories more vivid. And if that's the hook that you're hanging those memories on, it can make it really difficult to access. There are lots of other ways of doing it. We can use bodily processing. There are other things, but they are not the primary techniques that we do tend to talk about and work with. But visualization is really common. Just look at things like mindfulness, guided imagery, relaxation. They're everywhere. You can download apps and listen to all sorts of different things. It's very prevalent in mental health care.
In terms of EMDR, something else that I found really interesting from the interviews was that a lot of people said EMDR didn't work if they were just using the eye movement techniques, but there are other forms of EMDR that's actually not proper EMDR. It's not eye movement, but some people use finger tapping on the knees. And someone with aphantasia found that extremely helpful. Instead of using this sort of vision-based technique, they were using this body movement technique that worked for them.
Yeah, there are some practitioners who are starting to coin the phrase percussion therapy, which is using the same. What it is, in the way that it works, is it's activating and changing the way that our brains store memory. And eye movement is the more classic way of doing this, but it's trying to bring the two hemispheres of the brain and the way that the brain kind of works to process the memory in a different way. And you can use it either as percussive therapy, but different ways of accessing this to achieve the same result. And technically, it's not EMDR because of the lack of the eye movement element of it, but it's achieving the same thing.
Using the same underlying principles
Yeah.
in that as well. And is this maybe a good kind of next area for research? Is like, what are the other techniques and strategies that we might offer in replacement of visualization?
Absolutely. And that's the next step that we're working on. So first we had to identify whether or not there was a problem and what the problems might be. And part of the questionnaire and the questions we were asking was around, well, what does work then? What doesn't? And what does work? What do we need to leave out? What do we need to incorporate? And the next piece of research that I'll be working with a group of therapists looking cross-modally. So there's lots of different modalities that we'll be looking at to develop a different approach or intervention.
I'm going to transition to some of the questions. First, I'll get to a couple here from our members that submitted before the presentation. Let's start here. How might we raise more awareness about aphantasia in the mental health care community? So I know we just maybe touched on, but is there anything else you think we can be doing to make sure that aphantasia is, something that people know about?
Yeah, I think that when you go as an aphant to therapy and you start talking about aphantasia, not just going, yeah, this is my experience, but to be able to point them towards research to identify that actually, yeah, this is a thing and that this is something that we're talking about, as well as having access to more, I keep saying accredited, but recognized professional programs and courses and things, and to think about the way that we're training our therapists a little bit.
Yeah, and like you said, Bridget, a lot of these techniques are evidence-based. So we need to do this research to create the evidence base because there is none right now.
Let's move on to the next one. What is one important recommendation or consideration for mental health care professional providing therapy or counseling to clients with aphantasia?
I think the absolute most important, and it applies whether or not you have aphantasia, is to listen to your client. And I know that sounds really obvious, but listening and building that therapeutic alliance, that therapeutic relationship is so important, far more important than any technique that can be developed, because listening to somebody and really listening to them and trying to understand their experiences is a skill, really a skill of itself. And it's one that requires a lot of personal understanding and to understand yourself a lot more, and work out whether or not you're struggling to identify or to recognize somebody else's experience.
Just as maybe a summary for those who might have joined us a little bit late, did you find any specific mental health conditions that seem more common with those with aphantasia?
Not really. Usually the prevalence was pretty similar between aphantasics and imagers. I feel like there is a risk that people with aphantasia may be more likely to be misdiagnosed or misevaluated for something, depending on their symptoms that they're experiencing. One of the people we interviewed, actually, a couple of people we interviewed said that they had been diagnosed with borderline personality disorder, I believe. And they felt that they had been misdiagnosed because they were always very present and they didn't think about people when it's not in front of them. And the way that they explained it was like the therapist felt like they were like different people in different situations because they were always very present, and might potentially lead to some misunderstandings about what they're actually feeling. Is it aphantasia or is it this condition? But I don't think actually that any condition is more prevalent. I think what it will turn out to be is that once we have a better way of evaluating and diagnosing these symptoms in people with aphantasia, it'll turn out that it's actually very similar. It's just they're experiencing the symptoms differently.
Really well said. How can people follow your work?
I have on a professional website, ReshanneReeder.com, where I update my work a lot. You can follow me on Twitter also. I think my Twitter handle is somewhere in my biography, maybe. I don't know. Is that something that can be added on the website, or?
We'll definitely add that below into the description for one who's watching afterwards.
I
And we'll
can
also
totally
retweet those. So we'll retweet this on the Aphantasia Network Twitter, and we'll tag Bridget. Are you on Twitter as well?
Yes, I am. I'm also on Twitter. Yeah, and this paper that we're discussing is available in preprint at the moment, and we're just getting to the point of finishing the sort of publication-y bits that go alongside getting these kinds of papers out there.
Thank you again for our guest researchers, Reshanne and Bridget. I think they did a really great job, and thank you to everyone for joining as we continue to grow awareness and access to support for aphantasics worldwide. All the links will be in the description of the video, and I hope to see you next time.